Sorry to hear that, Rick. Comment from Rick. Thank you. Mine started when I was 17. The average onset of DPRD is in teenage years. So it's very, very typical onset age, usually either through trauma or use of cannabis. But there are obviously other triggers as well. For example, sometimes it can be flu medication or other prescribed medications. Sometimes it can be postnatal as well. Thank you, Alina Amygdala. Great name. Evie Hooper is just asking, is it common to misdiagnose with something else as opposed to DPRD? Yeah, really common. I think what tends to happen, we'll talk about this a little bit in the session, is I think doctors, psychiatrists, GPs are not confident in knowing about or diagnosing or treating depersonalisation, and thus they look for something they do know about. So they attribute the symptoms you're having to something else. So you can very, very often get misdiagnosed. The other thing that I think can happen quite frequently is depersonalisation can be a symptom as well as a disorder. So you can end up having not having depersonalisation disorder, but having it as a symptom of something else. And doctors often know about that. And thus they will look to diagnose you with something else with symptoms of DPRD. What we're really struggling to get awareness of is the fact that it exists as a primary disorder for a lot of us, and that it's constant for a lot of us 24/7. Just a couple of questions about cannabis there from Brooklyn. It's an interesting question. I think about 50% of us can have got chronic depersonalisation from use of cannabis, often single time use of cannabis, so using it once or twice or infrequently. But what's quite interesting about that is that the physiology of it, so what you see on a brain scan, because in case some people aren't aware, you can actually see depersonalisation on a brain scan as the insula, which is a small part of the brain, quite deep in the brain, not functioning properly. And the prefrontal cortex being overactive. When you see a brain scan of somebody who's had it triggered by cannabis or had it triggered by trauma or some other trigger, there's no difference. So it seems like the cannabis is a trigger for those that have a propensity to panic when they go into that feeling to do with smoking pot or hash or weed or something. But in and of itself, it's not the cannabis. The cannabis doesn't cause anything different from a trauma or any other form. We're dead on 7 now. So I'm going to kick off. So first of all, a huge welcome to everybody that's with us tonight. Many thanks for being with us. I'm going to try and swallow this mint really quickly. The session we're doing tonight is Pathways to Treatment. So we've already had 2 fantastic sessions from Heather and from Andreas, largely around symptomology, and really just answering those very generic overarching questions about DPRD. Now we're going to focus in a little bit more and talk about the process of getting a diagnosis and getting treatment and some of the obstacles you may come across whilst doing that. I'm just going to refer to some notes that Heather has kindly given me before I launch into talking about DPRD. So a couple of caveats. I'm not a medical professional. I'm talking today about my lived experience and from the experience of being involved in our charity, Unreal, that supports people with DPRD. I have personal experience of DPRD over many years, but I won't be offering specific medical advice. We may be speaking about subjects that are triggering. So if we are, I'll do my best to issue a trigger warning before that happens. Some of that will be obviously dictated by the nature of the questions we get. If you're finding a certain subject matter triggering, then the best way to handle it might be to leave the live session and watch it at a later date, the recorded session where you can kind of pause stop-start, and we will include trigger warnings in the description alongside the recorded version. If at any point during this call you feel you need urgent mental health support, then the team on Facebook and on Instagram will pick that up, and we'll give you details of who you should to signpost who you should go to. I am, as you'll have picked up by now, streaming live on Instagram and on Facebook, so my eyes might be darting around a little bit. If that's happening, then that's why I'm looking in between two screens. Next point is please comment with questions, but you're already doing that, so that's fantastic. I'll try and answer as many as I can. Those I don't get around to answering, we can pick up at a later date. Please obviously be supportive to one another in the comments. This is supposed to be a safe space where we can receive support from one another and give support to one another. So please do bear that in mind when you're commenting. Before we kick off then, just a little bit about Unreal. Unreal, as you'll know by now, I'm sure, is a mental health charity. We're the only UK charity that exists for depersonalisation and derealisation disorder. Depersonalisation, derealisation disorder is referred to as many different things. So DDD, DPDR, DP, many different things. In Unreal, we refer to it as DPRD. Depersonalisation and derealisation disorder. So that's what I'll be using in this session. Unreal were formally established at the end of 2019. So we're a fledgling charity, but we've been working extremely hard over the last months to a year to get things off the ground. We are here to reach out to people who have lived experience of DPRD. So that's people that suffer from it, have a diagnosis of it, but also their carers, their families, their friends. We're looking to raise awareness of it so people can get diagnoses first time round, not 3, 4, 5 years down the road. And to promote involvement, people coming together, so coming out of feeling particularly isolated, coming together. We have a website, unrealuk.org. There's lots of resources on there. I may mention some of those resources during the course of this session. And you can find them on the website. You can also on the website sign up to be on our newsletter, where we'll have campaigning opportunities, updates on peer support activities we're doing, updates on successes the charity's having, etc., etc. So please do pop onto the website and do that. There'll be my colleagues on the board will be on the board of Unreal, will be on Instagram and on Facebook, and will be helping me to answer some of the questions along the way. Two other things before we launch in. One is that you'll see I'm wearing sunglasses. Sunglasses really help me. My DPRD is massively linked to anxiety. So I've got polarizing sunglasses and I often use them. So if I pull my sunglasses down and look a bit strange, wearing sunglasses at 7:30 p.m, that's why. And the other thing to say quite cheekily is that one of our fantastic ambassadors, the singer-songwriter Dodie, it's her birthday this week, and there's a fundraiser that her fans have put out for Unreal on her behalf. So raising money for Unreal. We're about £50 away from our target, which is £1,000. So if anybody feels that they can offer a bit of support to us at this time, we'd be really grateful. And I'm sure my board colleagues will be putting something in the on both Instagram and Facebook for you to link to that, should you wish to. So today we're going to look at pathways to treatment. Few bits and pieces I'd like to cover. One, I'll just briefly run through my story, but rather than focusing really on kind of symptomology and recovery, I did recover for a number of years, for 6, 7, 8 years. So if anybody's interested in that at a later date, I'm happy to talk about it. But here I'll talk mainly on treatment and how I got treatment. Then I'll run through you the process to getting treatment and how to manage that process, and then what to do if you can't get specialist help for any reason, and then we'll deal with some questions as well. Big caveat out there, these are my views only. They're going to be quite frank, because I've had, as I'm sure of you can, as will resonate with a lot of you, I'm guessing, I've had quite a tough time navigating the health system. And I want to share with you what I've learned along the way, but they will be quite frank views, and they are just my views. And secondly, just to say that I'm talking about the process in the UK. If you're joining us from anywhere else, it will obviously be different, but some of the techniques should still be quite relevant to you. I'm just stopping there to see what comments we've got. Meetups in London, yes, but not in kind of coronavirus time. And colleagues on Instagram will be able to give you details of those, Rick, and where you can find that on our website. Any other comments there at the moment? Don't think so. Okay, so I'm going to launch straight in that case. So my story, I'm 36 now, almost 37. I got ill at university when I was 18. I got ill from single use of cannabis. I took it in a yogurt. I took it once and didn't feel any effect. So I had another yogurt with another dose of cannabis in it. And on taking the second yogurt, as soon as I took the second one, the first one hit me quite hard. I had a panic attack, which lasted quite some hours. Some of you might be familiar with that. So just circling through sort of catastrophic panic throughout the course of the evening. Had what I suppose is a normal reaction to cannabis, which is my eyes weren't really following me around the room. Everything was slow and I felt like I was removed essentially from the room, sort of sitting in the back of my head. And I eventually managed to drop off to sleep and woke up the next morning, and that was the start of having that feeling of the world not being real and me not being able to connect to it. Had that feeling then for 3 years, 24/7, which will be familiar to a lot of you on the line, I'm sure. I then completely recovered, fully recovered for a good 8, 9, 10 years. So it would be kind of about 21. So let's say I went back in at about the age of 29, I think, so about 8 years. When I went back in, it was off the back of a panic attack again. For me, it was trying to withdraw from the antidepressants that pushed me back into it. And it's lighter this time than it has been on previous occasions. But it's I'm using the same techniques and I'm not getting better essentially. So this one has been about 5, 6 years long already, and I don't seem to be coming out of it. I don't seem to be managing to recover from it. But as I say, it's fairly light. I've experienced it in much deeper fashion than the way I'm experiencing it now. When I first went to my doctor when I was 18 and very, very frightened, I was told to go away for a month. I've got some questions about recovery on Instagram, which I will come back to, I promise. If not in this session, then we can always do another one on recovery. I went to my doctor and was told to go away for a month. I went and sat in my room and panicked. And I went back after 2 weeks. And he said, go away for another month, nothing more. And I went away, went back in another 2 weeks, and he handed me a packet of antidepressants. That was it, nothing more. No context, no idea what the antidepressants would do, why I was taking them, what I might be experiencing, nothing. I took the antidepressants, and obviously not being young, not really knowing what to expect, it was quite an unpleasant experience on top of what I was already experiencing with the depersonalisation. Obviously, my life has sort of been, I'm sure this resonates with a lot of people online, but my life has sort of been taken away from one moment to the next. One moment, everything was kind of laid out in front of me, and I was, really looking forward to exploring life and had plans. And then in the next instance, they're gone. So there's that very, very low panicky point, and it's 24/7, and you just, everything's going through your head. Do I have a brain tumor? Will I never get better? What if I, etc., etc. I then went to a university doctor because I was in my first time at university. I'd seen my family doctor before. University doctor was a lot more clued up. She did things like sent me for a brain scan and did some basic tests, called the drugs line to see if there was any news, anything on single use of cannabis that was helpful. They had nothing at that point. I would hope that will be different now. I don't think she, by any stretch of the imagination, thought that anything would come back on the brain scan, but she understood that I needed to rule that out for reassurance so that I could move forward. So I had moved a step forward in my kind of relationship with clinicians at that point. It wasn't there until I'd been in 18 months of therapy for I don't know what. It kept changing between PTSD, anxiety, depression, when my therapist suggested to me that I might like to see the in-house psychiatrist because there was a new antidepressant on the market, which I thought might be good for me. And when I saw the psychiatrist, he said, well, explain your symptoms to me. And so I went through my symptoms and he said to me, well, so are you experiencing depersonalisation or derealisation? And it was just a bit of a lightning bolt moment for me. Because as soon as he said the words, I knew that it fit what I had been feeling. It obviously didn't solve the problem, but diagnosis gave me something to work with. It gave me something to research. It made me feel much less isolated. It validated what I'd been feeling, allowed me to rule out other things. So diagnosis was really important to me. I don't think that psychiatrist had an awareness of depersonalisation or DPRD as a disorder, but he gave me the terms to work with, so that was quite helpful. I never made it to get any specialist treatment because I was too early. So although I made it to the Maudsley Hospital, the specialist hospital for depersonalisation, it was still a research function at that point. So I saw them, but they were using me for research rather than providing me with specialist treatment. So that's kind of my experience through the system. But now I'd just like to take you a little bit through the process generally of getting that help, and then some of the hows of doing it. So some of you might be aware of this, but the process essentially to getting specialist treatment is it is a tertiary level of care. So your GP is your primary level of care. Your secondary level of care is your specialist. So it might be a neurologist or I don't know, an ear, nose and throat specialist, something like that. And then there's another level of very specialist care. And that's tertiary care, essentially. So in order to get specialist care for depersonalisation, you have to go all the way through to tertiary care. That means you've got to jump quite a few hurdles. So you've got to go through your GP. Your GP has to then refer you on to a psychiatrist. A psychiatrist then has to diagnose you with depersonalisation disorder and make a recommendation that you need specialist treatment. That recommendation then has to go to your clinical commissioning group, which is a group in your local area that decides how to spend money on medical care. It will look at the case made by your psychiatrist, decide whether it thinks you should be funded for specialist care, come to a decision, send that back to your GP, and then your GP will let you know whether you have been granted the funding to go to specialist care. In the case of the Maudsley specifically, that funding is only for your assessment. So you get funding to go and have your assessment at the Maudsley, and that assessment will then tell you whether or not you're being recommended for funding for treatment there. Okay, so I can see someone doing some crazy emojis on Instagram. It's really very complicated. There are a number of steps to it. If after your assessment at the Maudsley you are recommended for that specialist treatment, it goes back to the CCG accepts, and then you go on a waiting list for that treatment. Now, we're now lucky in that we don't just have the Maudsley. We also have Dr. Elaine Hunter treats people on the NHS herself now. And I'm sure one of my lovely board members will write down the name of her clinic, but I think it's just the depersonalisation clinic. So we've now got two avenues we can go down. We can go down the Maudsley, or we can go to the depersonalisation clinic on the NHS. But you can see that the whole process is very convoluted, from GP through to psychiatrist, through to a letter going to CCG, acceptance going back to your GP, you hearing about it, you going for your assessment, getting recommended for specialist treatment, that getting accepted, then you go on a waiting list, and then you get your specialist treatment. No, she hasn't retired, Rich. She's just set up the depersonalisation clinic outside of the Maudsley. Roses and Bones has just made a really good comment. With someone with anxiety and DPD, that process sounds terrifying. So I think this is one of the really big obstacles, and it's something Unreal would like to tackle, that when you're trying to advocate for yourself in that situation, it's really, really very, very difficult to do. You're feeling the most vulnerable probably that you've ever felt in your life, and you need to be the strongest and most robust and most efficient and most organised to get through that process. But let's dig into that a little bit and talk about the actual some sort of tips for getting through that process. So I certainly, when I went to my GP, I felt extremely nervous. I couldn't articulate what was going on for me. I wasn't confident in what I was saying. I was looking for a lot of support. I was feeling extremely fragile, extremely vulnerable. And then even when I did manage to articulate it, there was nothing coming back to suggest that anybody understood what I was trying to describe. A couple of tips then for what I think I've learned in hindsight. The first one is that regardless of what you're going to see your GP about, or regardless of what you're going to see any clinician about, you have the right to be listened to with respect and with curiosity. If you're not getting that, then you can always change doctors. So you always have the option to say, I want to see another GP. And there's absolutely nothing wrong with trying 3, 4, 5 GPs in the same practice until you find somebody who is going to be open enough to listen to what's happening for you. I would also say, I'm not sure if everybody's aware, but when you go and see a GP, you can request a double appointment. So if it's extremely stressful to you to think about trying to articulate what's happening and tell your story in a 10-minute time slot, you can request to the receptionist as you're booking the appointment that you need a double appointment because it's quite a complex issue and you need the time to describe it. So that is something that you can do that can take the pressure off. It's possible that your GP or psychiatrist will respond better to things that are essentially in their language. If that's the case, we have resources on the website. So I think sometimes you can get that response. I don't know if anybody's had it about, oh, you've been Googling this, have you? Oh, there's somebody on the internet that's got this, have they? And that can be really quite frustrating when all you're doing is trying to use resources to articulate what's happening for you. We have resources on the website which are written in essentially in clinicians' language. So there's the British Medical Journal article, which is written in their language by a publication that they respect, and explains the disorder. So I'd recommend that it might be helpful to bring that along. We've also got a graphic, a kind of a flow chart on there, which is also from the BMJ article, which shows all the different symptoms and where they should be referring you and for what treatment. And it's really worth bringing that along as well. If you are in a situation where you're feeling really stressed and really anxious, that can do the talking for you. I was also going to say, if you're feeling very nervous before you go and you can bring an advocate with you, you can take that person into the surgery with you. I know that's not always possible because some people are having as much of an issue explaining to their friends and family what's happening as they are to their clinicians. But if that is possible, then it's well worth doing. If you can write things down before, I think that's really helpful as well. What I would say is that GP also doesn't necessarily have to understand what you're going through. All that GP is there for is to provide you with a referral to the psychiatrist in this situation. So your one objective, your one focus when you see your GP is to get a referral. Oh, I think I've got something coming through on WhatsApp there. Heather, I'll have a look at that in just a second if that's all right. I'm afraid I'm going to cut off the Instagram live feed otherwise. So if you're not getting across all the emotions, if you're not able to articulate everything that's happening for you, if you leave that surgery having got a referral to a psychiatrist, then you're that you've achieved your objective, as it were. I've got Ellie. How do you explain what's going on without them feeling that you're telling them what to do? Yeah, it's a difficult one. So I think be objective, be calm, be clear about what you're in there for, Ellie, and then allow them to come to their own conclusion. And if they're a GP worth their salt, then they should come to the conclusion that what you need is a referral to a psychiatrist in that situation. And I'd probably advise looking for another GP if they don't come to that conclusion. I would say don't expect them to have heard of it. It's certainly not the GPs and probably not the psychiatrist. So instead of kind of going in this kind of paternalistic relationship of, the doctor knows everything, I've been with that more of a sense that that you're trying to build a relationship with them. It's a bit from you and a bit from them. If you go in understanding that you're going to have to build that relationship and they're probably not going to have heard of DPRD, then you're probably in a stronger situation, because otherwise it can be quite disappointing getting in the room and offloading all of this and not getting anything reflected back at you or having anything understood, essentially, as it were. But yeah, single objective, focus on that single objective of walking out with a referral to a psychiatrist. A lot of what I've just said, I think, is relevant to when you're with the psychiatrist as well. Bring an advocate if you can, write things down, bring resources with you. It's harder to see a second psychiatrist if you're going through the NHS process, but if you want to, you always go back to your GP and say, I need to see somebody else. And they can potentially do that. I see Rhiannon, mine was triggered by surgery. I have heard of that before, Rhiannon. Also heard that it's triggered by prescription drugs sometimes, triggered by giving birth, so postnatal depersonalisation. So I think that's, I've heard of that before. A couple of notes for when it goes to the CCG. It's likely, you almost want to, that acronym, that kind of metaphor people use where when you're driving, in order to be safe, imagine that everybody else around you is a bad driver. You sort of, it's sort of useful to go into the CCG process, I think, thinking that the process is going to go wrong because there's lots of ways in which it can go wrong, essentially. Which means that where you shouldn't have to do anything, you should just have to wait for the result to come back from the CCG. You may well find that you need to guide and push and chase on that process with the CCG. Again, that's extremely difficult to do when you're feeling really, really vulnerable. So obviously it's about doing what you can when you can. But I would say go into the process expecting that it's going to have to be you that makes the phone call and say, has the referral been made? Has the GP definitely made the referral? When is the next date of the CCG? And then the next week, has the meeting happened? Do we have a result? Has the GP received it? Do I need to book an appointment with the GP? So all of that kind of pushing and chasing, unfortunately, it often falls to us. And I've seen referrals actually be delayed for 6 months to a year just because it's got stuck somewhere in somebody's inbox and it hasn't been moved forward. So if you do have the strength to do it, or if you have someone that can do it for you, and I know that's not always possible, then please do that because it can really speed things up. I've got one here. Do you get a sense of chronic stress or restlessness? Yeah, definitely. And mine is massively related to anxiety. So I'll often get kind of restless legs in bed at night where I can't sleep because I can't keep my legs still. I sometimes get slightly kind of hypermanic if my DP is quite light, but my anxiety is slightly out of control. I'll get a little bit like that sometimes. But yeah, massively linked to anxiety for me. So that's the kind of my tips that I'm sharing with you in terms of GP, psychiatrist, and CCG. You can't get access to specialist treatment, and we know that you can't, for example, get specialist treatment if you are under 18. Then it's a slightly more difficult situation. So a couple of pointers. One, you can self-refer for CBT. I don't know if that's the same for under 18s, but if anybody else is having trouble getting just some short-term therapy, you can self-refer for CBT. You don't have to go through your GP to get that. And you can find it by going onto your local clinical commissioning group, which will be essentially your local borough. It's only 8 to 10 sessions, and they like to focus on anxiety or depression. So it's a little bit difficult guiding them away from that to depersonalisation. But sometimes it can just give you a kind of a space, even whilst you're waiting for more specialist treatments. If you can afford private treatment, I know a lot of us can't. If you can, and you've got a long wait to get to treatment, or you can't get specialist treatment because you're under 18, then I would really advocate auditioning therapists, as it were. So go and see lots of different therapists. It may be that you won't come across somebody that knows about DPRD, but what you might come across is somebody that's quite curious, quite open, quite willing to work with you, and quite willing to learn about things. And I've certainly had really good experiences with mixed therapies, so CBT, DBT, schema, kind of all in one bag, with therapists who are just particularly flexible, willing to learn, willing to work with me and build a relationship with me. Of course, it's not the same as specialist treatment, but if they are willing to learn, then there are lots of resources from the Maudsley and from Elaine, Dr. Elaine Hunter, and from Professor Tony David, that they can learn from and then bring back to their practice with you. So that's definitely an option for under 18s or those that can't get access to specialised treatment for other reasons. I think for me, the important thing is that you're looking to build sort of an equal relationship with somebody where you can kind of unpick things together and learn about things together. And you can bring your personal experience to it and they can bring their professional expertise to it. And sometimes I've had some success in relationships in that way. I've got, please, can you give some tips on how to handle DPRD on a day-to-day basis? What are some helpful techniques? Yeah, and I'm just looking at another one here, which I'll just go to first, which is DPD Diaries is helpfully saying it's Dr. Hunter is now able to see under 18s at the depersonalisation clinic. I'm not sure. If so, that's fantastic. She's certainly seeing international patients. I know that, which is super. Tips, that's Lecky Lou. So the biggest ones for me are distraction. So doing something with my day, but not pushing too, because obviously my brain's quite overloaded with trying to manage other things. So I really try and do fun things that I'm interested in, things that distract me. One is a bit of a fake it till you make it. So carry on with as many of your normal day-to-day activities as you feel able to. And the other one is that has always been useful for me is that I always get this thought cycle of I'll never get better, I'll never get better, I'll never get better. And it's kind of taking that feeling and letting it go constantly letting it go. And I find that quite exhausting because you're sort of doing it like thousands and thousands of times a day, but I do find it gets me somewhere in the end. Yeah, they're kind of my 3 kind of top tips on a day-to-day basis. Elsa is saying, I've always struggled with the question, why is feeling present important to you? Yeah, I think that raises quite an interesting philosophical point, that idea that, well, hang on, if we're functioning and we're able to do a lot of things and we have opinions and personality and characteristics, why is that so important? But there's something kind of fundamental about almost not being in control of your own life, even though you don't feel as though you are, sort of thing. I don't know why it's so fundamental to sense of self, but it certainly feels that it is to me. So I'm just looking at questions. Lydia, Facebook, can DPRD cause your head to feel fluey? Yeah, I know what you mean. It's almost that kind of fog. It almost feels very thick, like you're processing really slowly. I definitely get that quite a lot, Lydia, when the DPRD is deeper for me. I certainly feel like I'm kind of cognitively processing a much slower rate. So that is the general points that I had to make about pathways to treatment. If there's any questions on what I've gone through there, then do feel free to put on here. Otherwise, I'm just going to start to answer some of the questions that came in advance. So we've got, can it be a symptom of other mental health conditions? You're welcome, Lekili. Yeah, it can definitely be a symptom of other health conditions. So we know that depersonalisation can be a symptom of anxiety, can be a symptom of schizophrenia, can be a symptom of a number of different mental health conditions, but it can also be a symptom of physical health conditions as well, like it's a big one for epilepsy. So yeah, it definitely exists as a symptom, and it can definitely be comorbid with other physical and mental health problems. And this shift that that Unreal would like clinicians to get to is that it can also exist as a primary disorder on its own, or it can exist as a primary disorder where anxiety symptoms or depressive symptoms are part of it. Primary complaint is depersonalisation. Then we've got a question about RTMS and the success rate of that. So that's repetitive transcranial magnetic stimulation, which is a way. So if you're on early, you'll have heard me talk about the insula in the brain, which is underactive, and the prefrontal cortex is overactive. This gets a bit complicated now, but essentially there's as I understand it, again, not a medical professional, there's an inverse relationship between them. So if you push one down, the other pops up, and if you push that one down, this one pops up. So they can't get to the insula, but what they can do is put magnets over your prefrontal cortex, and they can deactivate that, so bring that down, make that less active. And then because of that inverse relationship, it should make the insula more active. And that's the point, and that's what they're trying to do, I think, with repetitive transcranial magnetic stimulation. I know that a few people have had it. Our ambassador, Dodie, has had it. I know a few other people have had it. I've heard people say that it's done nothing for them, and I've heard other people say that it's had a transient positive effect, so they felt better for a short period of time, and I've heard people say that it has worked for them. I know that the Maudsley did an experiment on it, and there's I think there's an academic paper that's been written on it. I don't know whether it's on our website or not, but there was certainly a paper that was written on it, and it essentially showed mixed results, I think. Linked to that, I think there's a question. There's a question: can you experience one without the other, depersonalisation without derealisation, or vice versa? I didn't catch who that was from, but yes, you absolutely can. I've heard people say that they only experience one experience than the other, and I've also had periods where I'm not experiencing any derealisation, so the world looks real around me, but in my head there's very slow processing, and I'm very drawn back in a dreamlike state, and then the derealisation kicks back in again. Is there anyone aware of research being conducted into what's actually happening in the brain during DPRD? So I think the research conducted in the UK, Chris, has been done by Professor Anthony David. I think the last piece of research he did was around RTMS, and that was targeting the insula. So that's the experiment that I've just talked about. But I think what he showed, and again, not a medical professional, so big caveat around that, what he showed, I think, is that you can see on a brain scan that the insula, which I think is responsible for your connection to the world, your response, your effective response to your surroundings, is underactive in people with DPRD. But I don't know what's been happening more recently, I'm afraid. But there's Omar on here saying there's a study being conducted in France now targeting the angular gyrus using RTMS. Don't know anything about that, but thanks, Omar. What have we got on here? Is it common to be misdiagnosed with something else? Yeah, so I think one of the things that I feel quite strongly about is that diagnosis is such an important part of the process, because it brings you out of isolation. It allows you to meet others who are experiencing something similar to you, and it validates what you're feeling. And I think what we often see is, because DPRD sufferers often go to clinicians and they talk about feeling like I'm in a dream, or feeling like I'm in the corner of the room, or I'm in the back of my head, or something like that, then we're often diagnosed as not being in touch with reality anymore. So therefore we're experiencing an episode, and therefore we can often get given antipsychotics, which, as I understand it, it's not happened to me, but as I understand it, can be quite damaging in the case of depersonalisation. So the resources I've been talking about from the BMJ, they are clear that if the sufferer is using metaphors and similes, so it feels like, it feels as if, it feels as though, rather than saying I am in the corner of the room or I am in a dream, then they're still in touch with reality. Then it's going to be depersonalisation and not psychosis. So we're trying to distinguish between those two states. But yeah, I think misdiagnosis is really common. We've got somebody on Instagram saying my psychiatrist doesn't want to diagnose me. That's really, really unfortunate. I don't really know where you go from there, apart from if you feel robust enough to challenge that decision. But that's a difficult thing to do, and would be quite stressful, I can imagine. Or you judge if you possibly can, which again I know isn't the easiest thing to do on the NHS. But yeah, that's a difficult situation to be in, and I'm sorry to hear that. We've got a question about how did you recover the first time round. So the first time round, I'm on an antidepressant. I'm on Venlafaxine. Necessarily advise it. I've had lots of problems with it. I've tried to come off it many times and haven't been able to, because I get recurrent panic attacks if I do. The first time round, I think, so a few things happened. First of all, I had to learn that it was linked to anxiety. That wasn't necessarily obvious, because I was so divorced from everything that I wasn't feeling any anxiety at all. And I had to come back a little bit more in order to start to feel the anxiety component there. So that was one thing. Then there was a lot of comfort zone, just slowly starting to do more and more things that I would normally have been doing in that situation, and giving myself a break from there's no point in me doing this because I'm not feeling anything anyway, which was my approach a lot of the time. What happened to me, and I started to get very interested in my course again at uni, but without putting pressure on myself. I had extended deadlines. I only went to university part-time, etc., etc. So it was about upping the interest, but keeping the pressure and the stress very, very low. The actual process of recovery for me was that I started to realise that I wasn't always aware of the depersonalisation. So I started to realise that in that moment I perhaps hadn't been always aware of it. And then I started to catch myself in moments where I wasn't aware of it. But as soon as I caught myself in that moment, it will come back. And then those moments grew longer and longer and longer. And then after another kind of 2 years in it, I got to the point where I could finally see myself, recognise that I felt present, and not tumble back into depersonalisation by recognising that fact. I would say that when I recovered, there's a question here about memories and memory gaps. I would say that when I recovered, all of the sort of problems I'd have in my memory, all of this kind of about myself, all of this inability to kind of own my long-term memories, even though I knew that they had happened, I didn't really feel connected to my kind of childhood memories, and all of that emotional intensity and the things that you feel that you've kind of lost. I got all of that back when I recovered. It all came back, and the depersonalisation felt like something had happened and now it had passed, and I was able to kind of pick up where I left off. So that was great. What I would say is that I've been trying to do that over the past 6 years, and it hasn't operated in the same way. So it's become chronic in a way for me now, and I'm struggling more to recover in the way that I had previously. Heather's just letting me know that Instagram will cut off after 60 minutes. So we might only have about another 3 minutes left. So I'll go through a couple of these other questions. There was a question about driving, about how you feel when you're driving. I feel like I shouldn't be on the road. I feel like I shouldn't be driving at all. I feel very fuzzy, and like my reactions aren't quick enough. And I find it very strange that nobody's telling me that I shouldn't be driving. I'm not sure that's particularly helpful. Maybe it resonates with other people that they feel the same when they're driving. Well, medications, maybe we do a separate session on medications, because there's a lot there in terms of clonazepam, the London cocktail, modafinil, lamotrigine, lots of potential options there. So then maybe that's another session that we do. Somebody agreeing with me on driving there, yeah. So just got some questions here that I think came through. I don't think I can look at them without stopping the session, but I will look at those questions afterwards and reply to them after the fact. So I think we're about to get cut off shortly from Instagram. So it's probably a good time to wrap things up. I hope that was useful. Obviously, it's not quite a peer support session because there's not quite the same interaction that we get in that way, but I hope it's nice still to have some sort of interaction during lockdown. I hope everyone's managing to stay safe and well in the current time, and I think we've got another one of these happening next week or the week after, hopefully. You're so welcome, Alia. You're so welcome, Saskia. Great to speak to you all. Unreal will be back at some point soon. Thank you very much. Bye-bye.